Thank you for joining us for this follow-up of our central venous access for point-of-care ultrasound. Today we're going to look at the peripheral venous access for point-of-care, some of the uses for it, and then some of the technique utilized behind it. So outcomes for today, we're going to have the learner be able to, hopefully, describe the context for the use of ultrasound-guided peripheral venous access, identify which candidates this approach may benefit, implement techniques for successful peripheral venous catheter placement, and discuss some roadblocks and pitfalls that can reduce efficiency of this approach. So the background of peripheral venous access utilized with point-of-care ultrasound is that ultrasound guidance has proved to be pretty useful for peripheral IV placement. Some of the things that can make an IV very challenging, which you're all too familiar with, I'm sure, would be the patient's weight, unusual anatomy, significant edema, history of IV drug use and damage to the veins, as well as dehydration or severe hypovolemia and other medical conditions such as sickle cell disease or diabetes. So first attempt failure rates of 39% are reported without ultrasound guidance. Second attempt failure rates are 12%. They found that with ultrasound-assisted IV placement that there hasn't necessarily been a huge decrease in number of attempts, but the time of the insertion and the overall ability to finally get a successful catheter placement has demonstrated that there is some benefit to utilizing the ultrasound guidance. Limited data also suggests better success with ultrasound, but no significant decrease in the number of attempts, like I mentioned. It's useful in avoiding central venous catheters in difficult peripheral IV placement patients. Lots of these patients, if multiple failed attempts, would require a different approach altogether, which would lead to having to move from a peripheral venous catheterization into a central venous catheterization. And that approach is going to be more risky for the patient. And so this just offers one more opportunity to get that peripheral venous access without having to go to a CVC. Studies of sites that employ ultrasound-guided peripheral venous access have demonstrated up to an 85% need to advance to the central venous access approach. So one of the challenges with peripheral venous access in ultrasound is that there's really no formal guidelines. And so because of different processes and different indications that different sites and institutions may use, they just really haven't come up with a formal set of guidelines. But what they have come out and said is that they do commit or they do recognize the benefits of ultrasound guidance to these catheter placements, but that they have to be done with a practitioner receiving some training before attempting the process. Mostly you're not going to see your everyday normal patients coming in and having to have ultrasound guidance for their IV placements or other peripheral catheter placements. Usually this is utilized when you've had that very challenging patient and want to use all the tools necessary to get a catheter in them without having to go to a central venous catheter. So some of the veins that we're going to be most likely to utilize ultrasound on to place these peripheral catheters are going to be the brachial vein, the cephalic vein, and the basilic vein. So we already talked about a number of these during our previous lectures, so we're just going to briefly go over where to identify these veins at. The brachial vein, you're really going to be seeing most of the time accessing it here in the antecubital region, sometimes proximally if that appears to be a better access point, but much of the time they're going to utilize the antecubital space here. The cephalic vein is more lateral in the arm, and so it would be more towards the lateral elbow with the patient in normal anatomic position. And then, of course, the basilic vein, which is going to be more medial, and then coming up to join the brachial here in the axillary region. So those are some of the common areas. Really at that antecubital region is probably where you're going to see this utilized most frequently. When determining the best placement site to utilize, you're going to be looking for the most shallow vessel, a vessel with a larger diameter, and non-tortuosity. So you want a nice straight vessel. So sometimes it may take some time kind of evaluating each of these options, looking for them throughout the length of the vessel until you determine what's going to be your optimal site. We also want to make sure that we're not going to be accessing an artery unintentionally, and so evaluating that vein, usually there's going to be 2 veins to 1 artery, looking for the collapsibility that we know veins have that arteries don't, and evaluating for phasicity of blood flows, where the blood flow is moving with the patient's breathing rather than moving with pulsatility like it would if it was on the arterial side. We can evaluate from all those things with our color imaging and our spectral imaging to help differentiate and let you know that you really are in the vessel you intend to be at. So the technique for this is going to be very similar to the central venous catheterization, but what we find is that we can use a little bit smaller transducer typically because these veins are very much more superficial. So the recommended transducer for peripheral venous catheter placement is going to be a hockey stick transducer that looks just like it describes, just like it sounds here. Now, if your site doesn't have a hockey stick, definitely your linear array high frequency will work just fine. Going with the highest frequency you can use will get you the best resolution, the clearest image, and so that's going to be optimal. If your patient is very thick, they have a lot of swelling, something like that is causing an increased depth to the vessel, then you might have to adjust that frequency down to the lower end. Your patients are usually going to be supine or sitting with an arm extended and externally rotated, most of the time giving us that really good access to the antecubital space. You want to set up your room so that you have the monitor straight ahead. You're not having to turn your head from one direction, look at the monitor, turn it back, and look at where your needle is advancing. So you want it all in a line so your eyes can quickly go from screen to arm, from screen to arm. The easiest way to typically identify the veins is going to be to start out in a transverse approach. You can also put a tourniquet on, as you can see this patient has here, in order to cause those veins to dilate a little bit, making them easier to identify. Make sure that you're setting the depth of your image no deeper than 2.5 centimeters, and that is considered because you typically don't want to go deeper than that in avoidance to hitting any sort of nerves or muscles that you're trying to avoid. So utilizing that, if it's not included in the image, you're not going to be tempted to go after it. So just making sure your depth is set very shallow at 2.5 centimeters is going to be optimal. So then you can scan through the veins, as I mentioned, and you're going to be looking for the size of the veins. The larger, the better. The depth, the more superficial, the better. And the proximity to an artery or nerve. Obviously, the closer it is to an artery or nerve, the more likely we are to have some sort of interaction with the artery or nerve, which we want to avoid. So you might end up having a beautiful vessel and end up going with a little bit more suboptimal vessel, but if it's farther away from arteries and veins, it might be preferable. And then obviously you want to make sure that you're not going to be placing a catheter into either an artery, which would be non-compressible, or into a non-compressible vein, which would indicate that there was a thrombus there. So one of the last things you want to do before selecting that artery for certain is to make sure that it compresses and that it's open and there's no thrombus. Once you've identified all of this, so you've picked your spot you want to utilize, then you can, of course, mark the site selected so you don't lose that as you get your patient all set up for the procedure. Now, once you've identified your where you want to insert your line, you're going to go ahead and gather all of your typical IV supplies. So in this case, because sometimes you'll be working with vessels that are a little bit deeper than maybe just an easy antecubital IV, you might have to go with a longer IV catheter needle. Sometimes they recommend from about 48 millimeters or 1.8 inches and up, depending on the depth of the vessel, which of course you have the opportunity to measure the depth of the vessel on your image before beginning the process, so that can help you determine which catheter you want to use. Make sure that you have about 2 times as much catheter in the vein than approaching the vein, and following that rule of thumb will also help you determine what catheter size you want to use. Then you're going to place the tourniquet proximal to the site, of course, to get that venous fill. Oftentimes this can be near the axillary region, but it's just going to depend on which vessel and which level that you're going for. Then, of course, you're going to follow your normal sterilization and skin prep procedures. Make sure you're going to clean the transducer face and cover it with sterile gel, and then utilize a sterile covering, a sterile probe cover, or a sterile lining to make sure that you are not carrying bacteria into the field. With that, then you're going to have to use another pack of sterile gel to make contact with the skin, and then you can make the determination on whether you want to utilize local anesthetic, or if you feel like the vein is superficial enough that you can go just directly into the vein. So at that point, you're just going to follow your typical IV insertion procedures. Now, as we talked about before when we were talking about the central venous catheter, you will have to make a decision on whether you want to start with a transverse or longitudinal approach. They have come to find that really for beginning, when you're beginning the procedure, haven't done a lot of them yet, that the transverse is typically found to be more easy to use, whereas the longitudinal can be a little bit more effective once you have a lot of experience under your belt. So there's no real known difference in success rate between the two approaches. The longitudinal is, like I said, typically a little bit more challenging, but often preferred by more experienced practitioners. When you're utilizing the transverse approach, you're going to make sure that you're going to take that transverse transducer, identify the area of the vessel where you want to go ahead and create your puncture site, and then you're going to center the needle to the transducer and advance it in that process we previously talked about, where you're angling the needle underneath the transducer and following the needle tip. So it will often have times, if your transducer is perpendicular, you'll angle your needle underneath it until you lose the tip of the needle, then stop the advancement of that needle, angle your transducer to follow the tip of the needle, and then re-advance the needle again until you get to the point where you are going to puncture the vessel. Then once you're going to puncture that vessel, then you can go ahead and consider, the needle has entered, you get your flashback, and then you can, of course, advance your catheter. And remember, you want about 2 times as much catheter in the vein as you want on the approach to the vein. If you're going in the longitudinal approach, you're going to identify the area of vessel in long, so you'd have the whole vessel laid out in front of you, and then you're going to center the catheter to the center of the top narrow end of the transducer, and then you're going to advance that needle along the long axis of the transducer directly into the vessel. And because you're in the longitudinal orientation, you'll actually be able to follow the tip and the body of the needle all the way through the advancement process. Then just as the needle gets towards the vessel, you will actually identify that tenting of the skin right before it punctures, and once it punctures, then you'll get your flashback. At that point, again, you can advance your catheter and proceed with the procedure from there. So here's just an example of the transverse versus longitudinal approach. So here we can see the transducer is in transverse, obviously, at the top, and you can see that they're utilizing a hockey stick. They're taking that transverse approach, so the vessel is going to look like this in transverse, and as they advance this, they're going to see that needle enter into the vessel, but they're going to have to do that. They're only going to see the area of the needle under the transducer at the particular moment in time. So as they advance, they're going to have to stop, angle the transducer, advance some more, stop, angle the transducer, following the tip so that they know they don't penetrate all the way into the vessel and then through. Now here shows a little bit of the challenge with scanning a vessel in long. You can see that there is actually no vessel really per se in this particular image. And so what happens oftentimes is, because it's such a narrow area, which you're going to have alignment with that vessel in long, it is very easy, especially with your non-dominant hand, to kind of roll off of the vessel. So this practitioner would want to stop where they're at, kind of fan the transducer back and forth until they picked up the center of the vessel, and then hold their hand incredibly still as they go ahead and advance that needle into the vessel. So In summary, ultrasound-guided peripheral venous access has been found to really increase the probability of successful peripheral venous catheter placement in challenging populations. It's not something that needs to be utilized on everyone, but for those that are really a struggle in getting a line in, this can be the key to success. There are currently very limited guidelines on this practice, but it has been found that training is considered essential when it comes to making this part of your repertoire in providing those difficult patient care procedures. Through vascular anatomy and sonographic appearance, knowledge is going to be essential in mastering this technique. And then also keep in mind, no vessels deeper than 2.5 centimeters or 1 inch should be accessed because of the possibility of disruption of a nerve in the process. So you want to limit your depth in these procedures to about 2.5 centimeters. So I hope you found some useful information in today's lecture, and I hope you have a wonderful day, and we'll see you back next week.